This episode is a continuation of Season 2, Episode 9, Estimates Today. Tim, Holland, and Matt Perron join Daniel and me to discuss the history, current state, and future state of patient estimates. We had some good laughs that caused us to go into a second episode. Please join us in Episode 10, Estimates Today, Part 2. And we're back.
All right. So I've heard about RTE, about getting eligibility information, but I've also heard about benefit collection. And for our listeners, what is benefit collection? Is that where we're storing RTE data? Is it something else? Like, how does this fit into the picture? Matt, do you want to start us out?
I'll start here. Sounds good. Yeah, after you've got all that information, and I think I called it a dance with the devil before. I've never called it that, but we'll go with that for now. After you've got all that information back from your real-time eligibility vendor, you got to figure out where to put it, right? Like it's great that typically an RTE response just sort of comes back and you can see it as part of like free text information. And that's well and good. But one, in that like free text field in the response, you have the ability to order it differently. And so how do you flow some of the stuff that's more important to the top, stuff that users have to look at each time, like maybe the general benefits, or like I said, radiology benefits, stuff like that you're going to look at 75% of the time, versus some of those specialty benefits that maybe are only applicable in very specific certain scenarios. So there's that part of it, like how do you just make it as user friendly as possible? I think there's some good standard tools for being able to do that within an EHR. But then the real key is like, okay, now we've got it. Now we got to file it, right? Like the system needs it filed discreetly so that, I can base my estimate off of it. Or if a user is going to look for it, it'll flow into these fields discreetly. I can display it discreetly. I can write rules, do all the things that you need to do within an EHR to be able to utilize that data appropriately. So that's, I think the big thing, it's kind of the next step. Like we're getting it back. Now we got to put it somewhere that makes sense.
You're going to hear me nerd out a little bit on that. So what's really cool about benefit collection is you can create areas or sections of the field that will specifically pull back discrete information from a service type code. So going back to what Matt was talking about earlier about specifically pulling back MRI or CT benefits, I can designate a spot within benefit collection specifically for that service type that is independent of the general deductible out-of-pocket and co-insurance, for example. Then that information would feed into the estimate. And if you want to start talking about automation and how you can kind of get things going from like the estimate side of the world, where you taking the user error out of it and making the computer do most of the heavy lifting, I can build a template for that MRI, force that template to look at the MRI CT service code, which forces the estimate to go back and pull that discrete information from that benefit collection field, and it starts to process the estimate, all without a user's interaction, that they can just review the end product and then convey that end product over to the patient. That to me is where the technology gets really, really cool.
And just like, I'm trying to think through the process here. So we've talked about RT, getting that initial information, putting in benefit collection. We've also talked about like getting the various charge data, contract data to pull in. Like what conversations, like when you're stepping in with a client to talk about like an estimate, what does the finished product look like, and how are we like what are the strategies that you're talking about to get that to the patient? Tim, like where would you start that conversation? Are there any like paths that you find to be more successful than others?
Yeah, so finished product, there's a couple of different things. You're going to have an estimate looks actually within Epic. So you're going to be able to see the actual charge and the contracted allowable from that charge or that CPT, and then what the patient liability is. And, you could start going into a lot of detail around how it's calculated with the benefit collection bit. But in addition to that, the estimate tool has the ability to generate a estimate letter. And so one of the first things that I like to make sure that we have, understanding around is like, okay, what is this estimate letter going to look like? Do we have the appropriate language on the estimate that makes us NSA and price transparency things compliant? And is that estimate letter consistent across your organization? Do you have just a couple of options that you can kind of fill in the information on this letter and then send it out? The next part of the conversation then becomes, how do you get that letter to the patient? So you've got a couple of options there as well. If they've got a chart, you can send it to my chart electronically, and as soon as you finalize the estimate, patients got the estimate within like microseconds. You can also mail the letter to the patient, and you can also, contact the patient via phone call. Then this is all dependent upon this individual health system's processes, et cetera. But call the patient, talk through the estimate, and then, email the PDF over to them. There's a million different ways to get it to them, but it's all going to have the necessary information that you have there. You're going to want to really nail down what your processes want to look like. Obviously, I'm going to promote my chart as much as possible, because there are things within my chart that you can then do as a result of having that estimate there, including reviewing it and then paying on it, like a prepayment from the estimate. So it all becomes very interconnected from an Epic perspective. That makes things so much more user-friendly from the patient's perspective to really make it I wouldn't say a fun experience, but at least an easy experience for patients. I mean, nobody's going to like paying the money, unfortunately, but it's at least it's an easy experience for your patient population, who is becoming more and more millennial and Gen Z, et cetera.
And then thinking about just like like we've got to the patient, we're following up on it. Are there any like tools, or just thinking about this, like how do we track the success of estimates? I know you mentioned that there's like various maybe metrics in Epic or other EMRs to say like we're within $50 or we're within $100 or whatnot. But is there like a team in place that like is tracking that? Are there what's your maintenance plan, or just like your overall strategy for like keeping an eye on this? Maybe, Matt, I don't know if you have that, or is Tim?
Matt's probably got the technical, and I've got the ops. Yeah. Okay. Yeah. So
go ahead, Tim.
So Epic's got a lot of dashboards that if set up correctly, and typically they're out of the box dashboards that will track your estimates. One thing about tracking estimate accuracy, you're typically looking months behind for that accuracy number. So I'm going to give you an estimate that's in advance of service, but I'm not going to know if that estimate is accurate or not until after the claim adjudicates, right? So you're talking about a month and a half at least before you start seeing those type of results come in. So typically the time frame is to look about 2 to 3 months back, determine like, okay, I have estimate A, and then claim A, was this in the same ballpark, yes or no? And then Epic can take that data and then like place it into a chart or a graph, and really show you, where you're successful and where you're not. Where it becomes very important to have a team is to start pulling together different subject matter experts, typically at a higher level, to start reviewing the outliers that you have there. Okay, what are the outliers? What services do you have in those outliers? Why were they an outlier? Was it because something was wrong with the charge, something was wrong with the allowable, which is the contract bit, or something didn't function correctly when it came to calculating what the patient responsibility was? And once you kind of zero in on what that reason was, then you can go back and start to correct things retroactively in Epic. Sometimes that gets a little more difficult because, especially with like surgery estimates, I'm going to estimate for a knee replacement that goes exactly right 100% of the time. What I can't account for, and thankfully we have this in the estimate language on the letter typically for the patient, is if the patient has another emergency while they're on the OR table, right? That's going to add a whole nother litany of charges that was not included in the initial estimate, and that's going to be one of those outliers. So you're going to have those situations as well that you just frankly are never going to be able to account for because you can't predict the future. But for those cases that do go exactly right, or a surgical estimate that you're having to do historical, Dr. Holland likes to use this particular knee replacement product 98% of the time, and these are the charges that he typically sees from a historical perspective 98% of the time. I can very confidently say that we're going to be in the ballpark from this perspective with that.
So it sounds like the out-of-the-box tools or reports or types of products that we have are pretty good and get us maybe 98% of the way there for what it is that we're looking at or what we need. 90.
Yeah. The rest of it is really going to be the team that you put together to monitor, and it really is something that you have to review on a relatively regular basis. Both from an accuracy perspective, I would recommend at least quarterly. And then from a charge capture perspective or charge master perspective, every time you make a charge master update, you're going to want to make sure that update makes it all the way down to the estimate. So that's an annual review typically that you're going to have to do. Same thing with contract and allowables. You're going to have that process. So it's very, very beneficial for the organization to have representation from those teams around the table at the strategic points in time where those things occur, to make sure that you remain accurate and you don't ever fall off the cliff.
So I think to elaborate a little bit more on the charge master or fee schedule update component of it. Where Tim said annual. So we're now seeing across the industry actually it being a biannual process, because more and more organizations fiscal years are on a different cycle than the federal calendar year. So with a regular calendar year. So a fiscal year typically might end for a lot of our education-based or academic facilities in June with a new July start date. We're seeing them have 2 pricing increases in the year. So with price changes come January with new CPT codes and HCPCS rollouts, and then they do their annual pricing increase. So they have to double check those estimates twice a year versus just once a year. So just for those organizations listening, those are things that you need to consider and anytime you have a major pricing structure change. So say you did a mid-year, you're on a regular calendar cycle, but you do a mid-year major overhaul to drugs or pharmaceuticals or those components of like what your markup tables might be. You also then have to redo your estimate component of that to ensure that it's going to pull that accuracy in as well. So just kind of putting that out there for those charge master team members who are listening in, or revenue integrity experts, you want to make sure you're putting your foot in to estimates throughout the year and that you're an active member of that team. I'm going to take us to a quick break. We're a little ahead of schedule, but I think it's a good place to pause. And we'll be right back. Vine Medical serves a growing base of more than 800 active hospitals and health systems nationwide. Their best practices are hardwired through technology solutions, proven to help hospitals achieve sustainable top performance. Their well-published results include improving financial performance, physician and staff alignment, patient experience, compliance, and patient safety and quality measures. Learn more at vinemedical.com. That's VYNE medical.com. And we're back. So I have a couple questions, and kind of that you guys have been sparking my thoughts on it. So they're kind of operational questions, Tim. So I'm going to point them to you, but Matt and Daniel jump in because you guys have a world of experience here as well. So the first is, thinking of like, okay, we have estimates, they're up and running, and and we'll come back to build a little bit more. Maybe this ties into build, but annually, everybody has to update. We get all the new codes from AMA and CMS, and some get sunsetted and some are brand new coming in. What should organizations be doing when an estimate's already been generated and now all of a sudden a code's no longer valid, or new codes need to be added to it because they've expanded it? So how should organizations kind of manage that? Or Tim, how have you seen, your past organizations doing that?
That is one of probably 100 reasons why I'm such a huge proponent of centralized revenue cycle functions, because it just makes things like that so much easier to manage and handle. So you've got a sunsetted CPT and you're replacing it with the other one. Epic is not going to automatically update with the new CPT if it has the same procedure. Now, if the order changes, say you have one CPT fall off and another one jump on because the provider decided to get you a CT instead of an MRI, different story, right? But when you have a CPT that's no longer in use, that Epic's not going to be able to do anything computer-wise about that. So having a central revenue cycle shop and having a very integrated team that can very effectively communicate that back to the necessary people is key. So typically where I would want to provide input is say, okay, that needs to be communicated early. Typically, you're going to find out about those types of sunset items pretty far in advance. And then you need to look at any and every estimate that you generated for the date of the sunset and after that, and then find a way to work and correct those. That can be done via work queues, via report export, whatever you want to do. I would recommend a work queue personally, but find a way to make sure that you're able to adapt to that change operationally at or before it's supposed to happen. But again, it goes back to making sure that you have a very streamlined revenue cycle, open lines of communication, and a work group or work plan to kind of plan through those types of things.
Have you seen organizations, just piggybacking on that, have you seen organizations in that regard honor, the prior estimate, and just, take a loss on a component of it if a code has fallen off? Or I'm just kind of trying to think, a lot of organizations are up to that last minute of annual updates where they're sliding the build in right around Christmas. And we also see a lot of revenue cycles now start to shut down around Christmas time or go skeleton crew because of financial constraints of trying to, hit target, give people time off with their families, but also help reduce, carrying over into the next calendar year. High APL usage or whatnot. So you're starting to see a lot of those things start to take place. So just kind of trying to think of, operationally, what have you seen? I mean, I've seen stuff from my operational experience in that regards. And then I'd love to hear more from Matt. Like, are there in our current, world of Epic, where we all play more of an expert in that regards, are there current reports or standard build, anything that's catching like that ahead of time for people to flag out, or is that more of a custom work queue type of setup? So kind of twofold.
So to answer the first part, and then I'll turn it over to Matt. Yeah, I would absolutely have a process in place that would honor the previous estimate. If you don't have a good way to capture or track that stuff in advance, I would recommend, if you're going to do that, to set up an adjustment code specifically for that is open and available for a certain amount of time, and then you kill the adjustment code. But that way you can carve out what those adjustments are. You can report on that. You can give that up to your VP of revenue cycle or your CFO or whoever it might be that wants to see that information. And you know that if this adjustment code was used, assuming that people are using the adjustment code for the right reason, that this is what this bucket of money is meant to represent. But yeah, I would absolutely honor the adjustment or the old price if there was a massive change from one price to the other.
Yeah, relate to the reporting or identifying those. Not a ton of experience, honestly, I should tell you that, Evan. But I mean, I can think of a couple different ways that you could certainly do it, whether it's looking at a report, building a work queue. I mean, that stuff is tracked in the system. So being able to write something like that doesn't seem like it'd be like super challenging. I mean, to Tim's earlier point, it's like, how far in advance do we know about stuff like this that's going to change, and how can we get out in front of it so that we can like look at, find me all these future estimates where this exists, and print them out on the list, and like, let's figure out a process for following up. So I don't think I've ever created something like that, but I don't think it'd be very hard.
I mean, to what Tim said earlier, though, like end of year, whatnot, there's like a million priorities. Sometimes it's easier just to honor the previous and just move on than trying to tackle all that.
Yeah, I think
a lot of times it's really, from the patient's perspective, the right thing to do, right? I mean, if you're going to want to save face as an organization and not cause a big splash, which unfortunately you're seeing a lot of these kind of things make the news media reels nowadays, that's probably going to be your safe bet.
Yeah, I think it's though the component, if I look at when I've implemented patient estimates or been on the projects with our clients or even pre-joining Wilshire, it's the component that's missing, right? We all think about like, let's get the estimate accurate, let's do this, but we don't always take into consideration annual updates or modifications and changes. And, that leads me kind of to my next operational question, what happens or how should organizations approach estimates related to the contracted payer plans or health plans coming and going in having even contract terms modify where, it might go from percentage charge to a fixed rate, or it could even go, or vice versa, or, some contracts just get termed, but we already quoted it as in network. So what are some of the operational or things that are out there that organizations should be leveraging around patients that have received an estimate to be able to kind of capture or target, those preventions of complaints or dissatisfied patients?
So I've actually been a part of those types of contract negotiations in my operational days. Side note, it's not fun. I would not recommend it. But when that happens and you're having a contract dispute with, say, United, and you're going out of network on this date, or you pass out of the date where United's gone from in network to out of network, and you have not signed the new contract, you're still negotiating, trying to figure things out. If you know that date's approaching, that your contract's ending, operationally, have your ducks in a row in terms of, okay, what's our payer mix? How many patients does United represent? And I should probably stop using the one payer, but does this payer represent, in your organization? Determine how many scheduled services are out there for this particular payer. There needs to be a marketing arm to this as well. You need to get ahead of this and make sure that your patient population is aware of what's going on with your organization, that you are in a networking concern, because I guarantee you that the payer is doing the same thing from their perspective. And then you need to start to develop a plan on how to account for any and all estimates that have already been sent out to patients. So that's typically pretty easy to build a report around and identify that patient mix. And then you just need to operationally sit down and go, okay, here's step 1, step 2, step 3. This is how we're going to address the situation. That at that point, it becomes more of a patient and customer service item that you're going to want to review, and less of like an epic build thing, right? I mean, that's just contract negotiations. But yeah, it's setting up a good operational plan to account for the inevitability of the contract going, out of date, and you're negotiating the new one, and then setting up, steps and expectations for your associates to take should that date pass, and be ready for it in advance.
Yeah, I totally agree. I'm actually helping one of our clients with kind of some contract termination stuff right now, and estimates was what I brought up. Like, wait, are we honoring these? Are we not honoring these? What are we going to do? In that regards, they had some unique language in their contract that allowed for a 90-day out for anything that was pre-scheduled. So, I mean, those are kind of things that people should consider if you're contract manager listening, or managed care coordination. I think it's one of those things of like, what are those out terms, especially around patients that have a pre-scheduled service, and making sure also that you assist your patients with continuity of care applications, because then we can honor things as in network still, based on if we can get it signed off on and apply some of those old contract terms at times. So versus treating them out of network, or do a single case, even if it ends up getting termed. So with that, let's lead back into build related type of things, or reports and dashboards. I have a couple of questions. So, hot industry trend now is, especially with Epic clients, is having patients be able to run their own estimate. So what is kind of your guys' best practice ideas on, self-patient generated estimate and accuracy checking comparison to organizational estimate, and how do you honor or not honor? Because I've seen lots of patient complaints recently where they self-generated an estimate and they thought that was their true estimate, versus it coming directly from the organization themselves saying, oh, nope, you missed these components, because it's only as good as what the patient knows.
Templates, lock it down as much as you possibly can. So even with your surgeries, right? So you can build a template for a surgery, and you can put so many CPTs or charges on that particular template. Every time you pull this template, that's what's going to fire. So if they're like going to your shoppable page, for example, I'm a known patient. I log in. I log in through my MyChart, and I want to run an estimate for one of my shoppable services that I have out there. I select the service. We already, as a MyChart patient, we already know what your insurance is. We know your subscriber ID. We know all the information we need to know to run an actual RTE in the background. The patient doesn't see that particular part. It happens behind the scenes. But you're able to then take the necessary bits of information from the template, which is going to be the charge and the allowable. You're going to take the necessary bits of information from the RTE, real-time eligibility for, again, the new users. That is going to bring in the patient liability bits that you need, and you're going to be able to spit out an estimate on the other end. There's never going to be, in my opinion, unless AI becomes like a super strong thing here, where you can account for a patient selecting the wrong estimate. But you need to have a process in place to be able to very clearly point that out to the patient, right? So, you know, Mr. Evan, you came in and you selected a knee replacement, but I'm sorry, you're having a shoulder replacement today. That kind of a conversation needs to happen. You need to be able to very clearly and very accurately describe what's going on and why. And that's honestly the only way you're going to be able to account from it from the customer service perspective.
Do you see a lot of patient? I mean, I don't. I see a lot of organizations, you know, still going back, even if a patient ran their own estimate and saying, hey, we've generated an estimate for your upcoming surgery or your upcoming procedure. Here's what it is. Even if it was patient, you know, self, but is there ability within the systems today that are out there on the market, like Epic, to be able to say, hey, this is what the patient's generating, this is what we're generating, where are we off, and how can we improve patient estimators within like MyChart to ensure that even that template gets them closer, or that the accuracy of what they're selecting gets them closer? I mean, it's still only as good as them putting in their benefit information, unless it's pulling it directly out of MyChart.
Right. I mean, if you're a known patient, you're using MyChart, yes, absolutely. All that information is reportable, and you can compare and contrast all that information. You know, your common thread there is the patient, the medical record number, or the HAR that you're doing this for. So yes, in that situation, you can absolutely get more and more accurate as time goes on. For your shoppable stuff, for your anonymous stuff, no, there's no way, because it's anonymous. There's no common denominator for you to tie that back to, unfortunately, unless you start to look at like trends of your shoppable estimates, and you see everybody running the wrong MRI, when in reality it's this other MRI. If you can identify that kind of a trend, well, then you can go back and look, okay, how are we describing this estimate on our shoppable page? Do I have the wrong name? Is it a confusing name? That our patients looking at this MRI because of the placement that this particular template holds on the website, versus the other MRI, which may be a couple of lines down and nobody's clicking on it. So you can make, like, you know, itty bitty little tweaks like that could help improve or help better direct patients. But that's about all you're going to be able to do from a shoppable perspective, anonymous shoppable perspective.
I remember when these were all starting to like first be rolled out, and to your point, not all the names are friendly or patient-friendly names for all the different services. I remember like logging in, like trying to do just test it out. I wanted to see how the product worked, and I was like, I have no clue like what the heck I'm selecting for like all these like various radiology exams. Stressing the importance of patient-friendly names for all these things. Having someone review that and take the time to like spell that out is extremely important for the patient experience, especially because this is really ultimately a patient-focused like endeavor that we're doing here. So make sure you can make it as friendly as possible.
Well, and I think
if I've got an estimate template, go ahead, Evan. I'm sorry.
Well, I was just going to say, and I think that what makes that difficult is where, you know, on the flip side for for your charge master, you're wanting to use the Medicare short or mid description so that it's accurate for a payer to understand, and that when they're looking up the code, and that you're leveraging the code correctly. So making sure that you're not using that, but you go and use the common name or the most the most universal name in that component for a patient, or even just putting it in a category, being able to say this is a labor and delivery, a vaginal delivery, and then it's pulling to that DRG, you know, complex vaginal delivery or C-section in that regards, and then it's pulling that price. but sometimes the patient wants to run both, or they end up running both, and making sure that that gets stamped into my chart is accurate so that they can see that. And then I think the portion that we still all have to figure out is how do we go and grab what the patient's running to just do some confirmations to even see are our templates pulling the right items and accuracy. That the part of the team that we haven't talked about being on there is your expected reimbursement team. So whether that's in-house or out of house, but having them do some verification to say, hey, are we expecting, when we're building out these estimates, are they calculating out what is our contracted expected terms? And those are usually, you see a lot of organizations using third-party vendors to help with expected reimbursement reviews versus in-house. So, and they become more of your contract experts as well, based off your rates, even if you're a net down and Epic organization.
Yeah. To comment on the patient-friendly names, it's part of some of the projects I've been a part of. I would go out and shop various, healthcare system, shoppable estimates and everything. And there were a couple I came across, like, I'm trying to get a estimate, but the name I'm selecting from is XR space right / KN space 1V. For those that don't know what the heck that means, that's X-ray right knee 1 view. Just type the word out, make it easy for the patient to understand more than anything else. So
that unfortunately does not even just apply just to estimates, just like the amount of patient facing materials. My wife went to an Epic shop and got like an after visit summary, and just like I was just like looking at all this stuff and I'm like, this is like all sorts of like Epic jargon or like bill jargon, like
yep.
maybe doesn't need to be on here.
Yep.
I wish there was a way to make this more streamlined, just make the patient, like, estimates have a nice feature where there is a patient friendly and then there's like the internal name. Take some time with that. I think it goes a long way.
And if
Absolutely.
you have a patient experience group, leverage that as well. Take your estimate names over to them and have those patient groups. And if you have that in place at your organization, it's a great opportunity for them to be involved, and you're getting their feedback on what's going to be patient facing to them so that they can actually provide you real-time feedback.
I've used marketing as well. Either way, yeah.
Find somebody who doesn't understand revenue cycle to do the review.
So this MRI I'm looking at, like what how do I yeah.
There's a CFO that I work with every day right now. And she reminds us all in meetings that if you use a term, does your mom understand it? And if you don't think your mom would understand it, then you need to spell it out. And that's hard for me because my mom's a nurse, so she understands a lot of our terms. But for the general person out there, I think it's definitely.
I totally relate to that. I can't tell you how many family members reach out to me about different revenue and insurance type things. So yeah, I completely relate to that.
Well, we're at another quick break, and we'll be right back.
There are thousands of medical offices and facilities across America, each navigating through changing regulations and reimbursement models while striving for positive patient experiences and outcomes. A common element in each of these facilities is patient access, the front line of both the revenue cycle and the patient experience. Though diverse in facility size and geography, patient access professionals unite around a common purpose: enhancing the overall patient experience to increase patient satisfaction and outcomes. Through it all, one organization is there to educate, connect, inform, and pave the way toward the future of patient access. The National Association of Healthcare Access Management recognizes the changing role of patient access professionals and their increased importance.
And we're back.
All right. So I mean, we've covered a lot here today. This is probably just the tip of the iceberg as it relates to estimates. I'm thinking about like I'm a listener. I'm building a team. Tim, where do we fit into that picture? And like, what do you want to leave our listeners with here?
I think Wilshire as an organization can fit in at any part of your project. We've got the expertise from both the operations perspective and also the technical perspective. So if you're just getting started, but you feel that either A, you don't have the bandwidth or resources, or B, you're not as familiar as you probably need to be with estimates and the regulations and the laws surrounding estimates and why they're important. Bring us in, bring an operational person in, and let us help you kind of structure that framework to make sure you're successful. Or if you're a little further down the road and you started the work group, but you're having some technical difficulties that you can't seem to figure out, bring us in from that perspective too, and start working through the technical bits with you and get that going. We've got a very robust patient access team with Wilshire that I love working with, I love collaborating with, and I think would be a very good fit for a number of organizations.
Even just on our little podcast here, we got like a whole squad here. We got the contracts, we got the operational front end, we got the technical front end, and Evan is kind of a smorgasbord of everything. So
yeah, smorgasbord. I guess that's good. So just we've kind of spent 2 full episodes now. This, as we're into episode 2 here and nearing the end of it. Kind of what are the big recaps that we should be thinking of, in that regards? Like, what do we want to leave everybody leaving with? We have our product, we have our team, and Matt and Tim have been working on a product offering around what we can do from a service advantage standpoint. But then, if people are trying to do this in-house, like, what do we want to recap? Because I don't want to make them all go all the way back to the first episode. I kind of do, though, so where our listeners our listeners get up. But let's just recap where we were.
Yeah, make sure you have a very comprehensive work group that includes not only your access team, but also representation from your revenue integrity, from your contract management or managed care team, your charge entry team, typically that lives in the revenue integrity world, something like that. Make sure that you have a cadence of meetings with this that is more than just on an annual basis. And you want to make sure that you're looking at different components. So if you're in the construction phase, making sure that we have the appropriate build in place to grab the correct charge, and then the appropriate build to make sure that we're looking at the correct contract, and making sure that everything is pulling in correctly from the real-time eligibility tool and how that feeds into the benefit collection bit. So having a very robust team there that includes all those operational people I mentioned and a good representation from your Epic IT side is going to be key to success. In terms of making sure that you have compliance from a regulatory perspective, make sure that you bring in the compliance team in a lot of cases, that you truly understand the requirements behind what price transparency is and no surprise act and what the difference is between the two. And then making sure that you're reacting accordingly, for each one of those regulations going forward. And then from the accuracy perspective, making sure that you've got a work group or a way to track that accuracy both within Epic to account for anything that's considered an outlier, and a way to address said outlier, going through and actually, doing a root cause analysis to figure out what actually happened and then working to correct from there where you can. And then making sure you account for any charge changes and updates. I think we covered CPT sunsets, like when they come out and say we're no longer going to use the CPT, this procedure is going to fall under the CPT now. Making sure you have a process around how to hopefully preemptively account for that. And yeah, it's a lot of operational setup. It's a lot of work group time that you're going to have to do. But if you get a structure and a cadence and you stick to it, I think you can be very successful.
Yeah, I think you can tell from what Tim described. It's got that trifecta of like very complex from a system perspective, very complex from an organizational perspective, complex from a regulatory perspective. I think that's what makes us a really good partner in this aspect. Even with the folks we have on the phone today, we all bring that expertise, and that's why I think Tim and I are very passionate about bringing this project and product to lots of our partners that we're working with, because it checks all those boxes for something that can provide a huge amount of benefit, is very hot topic with what we're dealing with today, and you need someone to really guide you to make it successful.
Yep.
I think just to add, the one part we haven't talked about as a group is as your organizations also are launching new product or service offerings, that this is part of that process and the go live of that process. If you can get ahead of it as those codes are being set up or new programs are being launched, make sure that you put it on your revenue cycle and your IS revenue cycle checklist as a part of that integration build. It tends to get missed until it's then needed downstream. So just putting that out there. Well, I think, Daniel, normally we would go to the Wilshire lab at this point, but we don't have any questions as of yet for this episode. So
well, yeah, we can wrap up here. Thanks, Matt. Thanks, Tim, for joining us and for bringing your smiling faces here. This Friday afternoon is when we're recording. If listeners want to reach out to you or engage with you on estimates and having you plugged in, what's the best way for folks to contact you? Tim, we'll start with you.
Yeah, so I've got a Wilshire email, t.holland@thewilshiregroup.net. It's a great way to get a hold of me if you need anything. Also have a LinkedIn profile you're happy to look up. Tim Holland is what I have on there, and I'm more than happy to help wherever I can.
Yeah, same for me. m.perron@thewilshiregroup.net, or definitely hit me up on LinkedIn. I got a couple comments and notes from our last Decision Trees podcast. So I appreciate that for all you that listen. So yeah, definitely hit me up on LinkedIn. Love to chat more about it.
Nobody's ever reached out to me on LinkedIn. Has anybody ever reached out to you, Evan?
Yeah. Next time I'll say no.
Shout out to Heath Hanwick from Epic for reaching out. I appreciate it.
We got to build up your celebrity profile there, Daniel.
Or maybe they've reached out to me. I just am not following close enough, or maybe it was just I thought it wasn't podcast related. But
it could be also your doesn't LinkedIn, they have like your direct ones and then like you're hidden in the background and you have to be like logged in online. That's where I've seen some of them. So all right, well, everybody, that's it for us today. Check out the episode. If you missed episode 1 or you missed episode 2, go check it out. And we'll see you next time. Bye-bye.
if you liked today's episode, continue to join Wilshire Wednesdays.
You can follow us on LinkedIn or Twitter at Evan_Wilshire. Daniel can be followed at Daniel_TWG. Wilshire Group at TWG Health. On Facebook at the Wilshire Group or on Instagram at Wilshire IT Revcast.
Remember, if you prefer to watch, come check us out at the Wilshire IT Revcast YouTube channel.
If you have an inquiry, want to share your thoughts, or get additional information on today's episode, email us at wilshirepodcast@thewilshiregroup.net.
The best way to support this podcast is to review, rate, and subscribe. See you next time.
Bye-bye.
The Wilshire IT Revcast is hosted, produced, and engineered by Evan Martin and Daniel Bianchini. It is executive produced by Gretchen Case, Hank Smither, and Spencer Thielman. The Wilshire Group. Experience you can trust, results you can count on.